All right, welcome to The Explainer. Today, we are diving deep into type 2 diabetes, but this isn't your textbook lecture. We're going to break down exactly what you need to know for your rotations, how to crush it on your boards, and, most importantly, how to really take amazing care of your patients. Okay, let's jump right in with a question you're going to get all the time in clinic. Your patient's sitting there, they feel totally fine, and you want to screen them for diabetes. Why, they'll ask. It seems like such a basic question, right? But the answer, well, the answer is everything when it comes to preventative medicine. So here's the game plan for today. We're going to walk through the whole patient journey, why we screen, how we diagnose, the core principles of management, the latest meds, and how to stop those long-term complications in their tracks. Let's get into it. All right, first up, the why. Why do we even screen for this? Let's talk about the silent threat. Here's the really crucial part. By the time someone actually feels sick, with the classic symptoms like being super thirsty or having to pee all the time, the damage is already well underway. Think of it like termites in a house. You don't see them, but for years, they've been silently chewing away at the foundation. We're talking about tiny blood vessels in the eyes and kidneys and the big ones in the heart and brain. Screening is our chance to find those termites before the house falls down. Okay, this is super high yield for your exams, so listen up. There are two big players setting the screening rules, the ADA and the USPSTF. The ADA says screen anyone with a BMI over 25 if they have a risk factor, and hey, just screen everyone over 35. The USPSTF is a little more streamlined. They say screen adults from 35 to 70 if they're overweight or obese. You've got to know the subtle differences here. It's gonna come up, I promise. So, you've screened your patient. Now what? Let's get into how we actually make the call. It really comes down to a few key numbers. All right, screenshot this, write it down, whatever you need to do, you have to have these numbers memorized. For an A1C, the magic number for diabetes is 6.5% or higher. Fasting glucose, that's 126. 2-hour glucose test, 200. And don't sleep on those pre-diabetes numbers. That's our sweet spot, our chance to really make a difference. Oh, and a huge clinical pearl. If your patient has no symptoms, you need 2 abnormal tests to lock in that diagnosis. Don't forget that part. But which test do you pick? It's not one size fits all. The A1C is super convenient, right? No fasting needed, but it can miss things and it gets thrown off by stuff like anemia. The fasting glucose is cheap and classic, but making someone fast for 8 hours is a pain. Then you've got the glucose tolerance test, the OGTT. It's the most sensitive, but man, it's a hassle for the patient. Knowing the pros and cons here is what separates a good clinician from a great one. You're making a strategic choice every time. Okay, diagnosis is in. Now for the main event. How do we manage this? Let's get into the modern playbook. And I'll tell you right now, this is about way more than just chasing a glucose number. Before we jump into treatment, let's just do a super quick review of what we're actually fighting here. It's a double whammy. First, you get insulin resistance. Imagine insulin is a key, and the cell is a lock. The lock gets rusty and the key doesn't work so well anymore. So what does the pancreas do? It makes more and more keys, but eventually the key-making factory, the beta cells, gets exhausted and starts to burn out. That's the second problem, not enough insulin. It's a progressive process, and that's key to how we think about managing it. 58%. Just let that sink in for a second. In this huge landmark study called the Diabetes Prevention Program, intensive lifestyle changes, we're talking diet, exercise, the whole deal, slash the risk of getting type 2 diabetes by 58%. You know what's wild? That was better than metformin, the go-to drug. This is why lifestyle isn't just a suggestion, it is the absolute foundation of everything we do. So this is your management algorithm in a nutshell. Step 1, always and forever, is lifestyle. Step 2, for pretty much everyone, is metformin. But step 3, this is where the game has totally changed. We don't just throw another drug at the A1C anymore. No, we look at the patient. Do they have heart disease, kidney problems? And we pick the next drug specifically to protect those organs. And that leads us right here to what is honestly the biggest revolution in diabetes care in a long time. We've stopped just treating the number, the A1C, and started treating the patient. This quote right here from the ADA guidelines says it all. If your patient has heart disease, heart failure, or kidney disease, you should be reaching for an SGLT2 inhibitor or a GLP-1 agonist. And here's the mind-blowing part. You do this even if their A1C is already at goal. Let me say that again. It's not about the sugar anymore. It's about protecting the heart and kidneys. So let's talk about these two game-changing drug classes. You've got the SGLT2 inhibitors, think empagliflozin, and you've got the GLP-1 receptor agonists. You've definitely heard of semaglutide. These aren't just your grandpa's diabetes meds. They do so much more than lower blood sugar. They've been proven in huge trials to stop heart attacks, to save kidneys, and to help with weight loss. It's incredible. This table breaks it down so clearly. Look, metformin is a fantastic starting point. But see those check marks for SGLT2s and GLP-1s? That's proven life-saving benefit for the heart and kidneys. So if your patient has, say, heart failure, you're not just picking another pill. You're picking an SGLT2 inhibitor because it can literally keep them out of the hospital. That second choice after metformin is probably one of the most critical decisions you will make for that patient. Okay, last section. Let's talk about playing the long game. Getting the diagnosis and starting the right meds, that's just getting on the field. The real work, the championship game, is about preventing those awful long-term complications. If you remember nothing else, remember this. What's the #1 killer of patients with diabetes? It's not high blood sugar, it's heart disease. Full stop. So when you're treating diabetes, what are you really treating? You're treating cardiovascular risk. That is the #1 threat to your patient's life. So how do we do that? It's as easy as ABC. A is for aspirin, but that's mostly for patients who've already had a heart attack or stroke. B is for blood pressure. We want it down, ideally less than 130/80. And C is for cholesterol. And this is a big one. Pretty much every single patient with diabetes between the ages of 40 and 75 needs to be on a statin. It's just standard of care. And we can't forget about the small blood vessels. This is your annual checklist every year without fail. Eyes, they need a dilated exam to check for retinopathy. Kidneys, they need a urine test, that UACR, to check for damage. And feet, you need to do a really good foot exam to check for neuropathy. Being religious about this schedule is how we stop people from going blind, needing dialysis, or losing a limb. It's that serious. So let's bring it all home. What's the big takeaway? It's that the entire goal of diabetes care has shifted under our feet. We've moved on from just chasing an A1C number. Our job now is to wrap our arms around the whole patient and reduce their lifetime risk of heart attacks, strokes, and kidney failure. It's a whole new ballgame. And that really leaves us with one final crucial question. The next time you walk into a room with a patient who has type 2 diabetes, I want you to ask yourself this. Am I just treating a number, or am I protecting a person? Am I just lowering the A1C, or am I protecting their heart, their kidneys, their eyes, their future? How you answer that question, that's what makes you a great doctor.